I'm Thomas Baldrick at the ASH 2014 conference. This is Dr. Rachid. He's from the Moffitt Cancer Center in Tampa, Florida. Thanks for coming by, sir.
Thank you for having me.
Tell us about this randomized phase 2 study that you've got data to present here.
So this is a study that we initiated a number of years ago. We have looked at the combination of cyclophosphamide and pomalidomide. And partly the reason underlying this is that pomalidomide and dexamethasone results in about a 30% response rate in patients with relapsed and refractory myeloma. And that's something we thought that we should try to improve on. So we sought to add cyclophosphamide orally as an all-oral regimen to try to get the benefits improved. We performed a phase 1 study looking at the recommended phase 2 dose of cyclophosphamide in addition to standard pomalidomide and dexamethasone, and previously reported that. And we completed the randomized phase 2 study comparing pomalidomide, cyclophosphamide, and dexamethasone to the pomalidomide and dexamethasone. Overall, we've noted an improvement in the overall response rate for the cyclophosphamide-containing arm. And we also noted, although not statistically significant, an improvement in the progression-free survival and a trend towards an improvement in the overall survival, even though this was a small study of approximately 70 patients that was really not powered to look at those differences. The toxicity profile of the combination was not markedly increased over pomalidomide and dexamethasone. We have noted an increased hematologic toxicity. However, this was also not statistically significantly higher, but would be totally expected when you add cyclophosphamide to this regimen. Overall, I think this is a regimen that is convenient, oral, and comparable to other pomalidomide-based regimen, and seems to be also cost-effective.
What do you think is most significant of the data you've got so far?
I think, truly the improvement in the response rate is not a little bit, it's quite a bit. I mean, we have an improvement in the response rate of greater than 30% between the two arms. And that's something that is statistically significant. The progression-free survival data looks consistent. For the comparator arm, the median PFS was 4 months, consistent with other published report, and the comparator arm was about 9.5 months. And that is also remarkable, even though this was associated with a p-value of 0.1, which is our 10% error rate for the randomized phase 2 study. This is nonetheless remarkable.
You mentioned the cost factor. How do you look at that?
I think it's important to look at this nowadays, especially given that a lot of the therapies that we have for myeloma are associated with significant costs to the patient, to payers, and overall to our society. When you look at a combination of an immunomodulatory agent with a proteasome inhibitor, the costs are going to be significantly more compared to an immunomodulatory agent with an oral drug like cyclophosphamide, which tends to be quite a bit cheaper. So this is something that perhaps may be able to maintain the efficacy at a lower cost, which is something definitely that we want to accomplish.
It's the real world, huh?
It is the real world.
Thank you, doctor, for coming by. Best of luck to you, sir.
Oh, pleasure.